Bismillahir Rahmanir Rahim. The lecture today is about the peripheral neuropathies. The objectives arranged for listing pathological mechanisms, approaching a patient with peripheral neuropathy, recognizing pattern of involvement, differentiating causes and investigations, and describing a treatment for each type. The peripheral nervous system, through its motor, sensory, and autonomic divisions, serves as a major interface between the central nervous system and the environment. Diseases of the peripheral nervous system, termed peripheral neuropathies, are among the most prevalent neurological conditions. The differential diagnosis of peripheral nerve disease can be challenging because the catalog of disorders that can produce neuropathies is extensive. The peripheral nerve consists of an electrically active core or axon and an externally fatty layer of electrical insulation known as myelin. The axonal integrity is critical to the action potential propagation along the cellular membranes of either motor or sensory nerve. Injury to the axon at any point along its course may block transmission. Myelin is also critical to the impulse transmission along the length of the axon and increases conduction velocity through salutatory conduction. In which an impulse leaps from node to node. It jump means this salutatory conduction means that the impulse will jump from the node to node between node of Ranvier, if you remember, between myelin segments. Demyelination disrupts salutatory conduction, slowing nerve conduction velocity. In addition, focal demyelination can cause sufficient leakage of axonal current to halt action potential propagation at a specific point along the nerve, causing what is called conduction block. The term peripheral neuropathy designates a disturbance in function of one or more peripheral nerves. Several types of peripheral neuropathies are distinguishable by the extent of involvement. The clinical deficit is usually a mixed one, and sensory symptoms and signs are often the initial feature of peripheral nerve involvement. The pathogenesis. Pathologically, nerve injuries can be divided into four major categories. First, neuronal degeneration, which results from damage to the motor or sensory nerve cell bodies with subsequent degeneration of either of their contiguous peripheral axon. So here, neuronal degeneration refers to the cell body with degeneration with its contiguous peripheral axon. Second, Wallerian degeneration results from damage to the axon at a specific point but below the cell body with a degeneration distal to the injury. Third, axonal degeneration results from diffuse axonal damage because the distal portion of the axon is the furthest from the cell body. It undergoes the earliest and most severe change during diffuse neuronal injury, accounting for initial symptoms in the feet and hands, followed by gradual proximal ascent with continued injury, the so-called dying back phenomenon. Recovery from axonal degeneration requires nerve regeneration, which is a disgracefully slow process. Number 4, the segmental demyelination, which results from injury to the myelin sheath without injury to the axon. Demyelination of the peripheral nerves at even a single site can block conduction, resulting in a functional deficit identical to that seen after axonal degeneration. In contrast to repair by regeneration, however, repair by remyelination can be quite rapid. Autoimmune attack on the myelin sheath occurs in the inflammatory demyelinating neuropathies. Now, approach to patient with peripheral neuropathy, we have to consider the following points. First, temporal profile means acute, subacute, or chronic, progressive course or relapsing remitting. Pattern of involvement, we will talk about after this. Sensory or motor or mixed, painful or painless. Autonomic involvement, cranial nerve involvement, evidence of involvement of other parts of the nervous system, evidence of skeletal deformity, past medical history, family history, any evidence of hypertrophic nerve, myelinated or axonal or mixed nerve fibers involvement, small or large nerve fibers, and finally skin, nail, and hair manifestation. What about pattern of involvement? First, mononeuropathy, which may be simplex, multiplex, and entrapment, refers to focal involvement of a single nerve trunk and therefore implies a local cause. Mononeuropathy, simplex, in which there is involvement of a single peripheral nerve, direct trauma, compression, and entrapment are the usual causes. Median neuropathy due to compression in the carpal tunnel constitute the great majority of mononeuropathies encountered in clinical practice. Cranial mononeuropathy, it is a neuropathy affecting individual cranial nerves and is a large subject and is dealt with separately. Facial, oculomotor, and abducens constitutes the great majority of cranial nerve involved. Mononeuropathy multiplex, which refers to the multifocal neuropathy. This term signifies that there is involvement of various nerves but in a symmetric manner and at different times, so that the individual nerves involved can usually be identified until the disorder reaches an advanced stage. Polyneuropathy, this refers to symmetrical simultaneous involvement of various nerves, and the closed and stalked pattern is the example. And finally, radiculopathy and plexopathy. Clinical features. It depends on the type and distribution of the nerves that are affected as well as on the severity of the disease. It may be motor, sensory, and autonomic. Motor features usually are of the lower motor neuron lesion. The first symptoms tend to be sensory and consist of tingling, prickling, burning, or band-like dysesthesia in the balls of the feet or tips of the toes, or in a general distribution over the soles. Sensory usually features of positive or negative phenomena. Autonomic feature, which are secretory, dry skin, eyes and mouth, and vasomotor symptoms like temperature instability, coldness, flushing, or postural hypotension, disturbance of the cardiac rhythm, bladder, bowel, gastric, and sexual functions. What about causes of peripheral neuropathy? First, hereditary neuropathies. Second, acquired, which can be classified as immune-mediated neuropathies, vasculitic, infectious, paraneoplastic, paraproteinemic neuropathies, like monoclonal gammopathies, which are common in the general population and occur in 10% of patients with peripheral neuropathy. A neuropathy associated with the granulomatous disease, and acquired immune demyelinating neuropathies, which is known as AIDP. Second type of acquired neuropathies is the metabolic neuropathies like diabetic, hepatic, uremic neuropathies. Other types of acquired drugs and toxin neuropathies, alcoholic neuropathy, neuropathies associated with nutritional deficiency, entrapment and compressive neuropathies, critical illness neuropathies, and finally idiopathic. Now we proceed to investigate a patient with peripheral neuropathy. EMG and nerve conduction studies is the single most important diagnostic test for the evaluation of neuropathy. Several blood studies should be considered. Commonly ordered laboratory test for evaluation of peripheral neuropathy includes all patients with a peripheral neuropathy should have a complete blood count, ESR or C-reactive protein, comprehensive metabolic panel like fasting blood sugar, glycated hemoglobin, renal function, liver function, thyroid function, test urinalysis, serum B12 and folate, and a serum protein electrophoresis with immune fixation. Immunological screening for connective tissue disorder, search for infectious processes, particularly HIV and hepatitis, Lyme titers, and rapid plasma reagent. Other blood studies may also be indicated, including assays for antibodies directed against specific nerve or myelin components, serum cryoglobulins, and serum and urine heavy metal screening may be needed. The lumbar puncture is especially important for diagnosis of acute inflammatory demyelinating polyneuropathies and chronic inflammatory demyelination polyradiculoneuropathies, which are known as AIDP and CIDP, and may provide additional information regarding infectious and neoplastic diseases as well. but it is not needed for the most neuropathy evaluations. The indications for nerve biopsy are highly limited, and it should be used sparingly, as harvesting of the sural nerve at the ankle, which is the most common procedure, carries a 10 to 15% risk of chronic neuropathic pain at the biopsy site. More refined diagnostic tools include quantitative sensory testing, autonomic studies, and skin biopsy with staining and quantitation of intraepidermal small sensory nerve fibers. Now, diabetic neuropathies. Diabetes is the most common cause of neuropathy, and approximately 50% having some degree of neuropathy. This includes type 1 insulin-dependent or juvenile diabetes and type 2 adult onset diabetes. However, only 2% of people with diabetes have symptoms of neuropathy, with the others often unaware that they have it unless it is identified during examination. Classification: A. Symmetric diabetic polyneuropathy. First, distal primarily sensory symmetric polyneuropathy. Second, sensory motor polyneuropathy. Third, autonomic neuropathy. 4, chronic evolving proximal motor neuropathy. B. Asymmetric diabetic mononeuropathies and plexopathies. First, cranial mononeuropathies like diabetic 3rd, diabetic 4th or 6th or 7th. Second, entrampment neuropathy in the limbs. And third, asymmetrical proximal motor neuropathy, which is called diabetic amyotrophy. If you look, the sensory, it is usually symmetric. Sensory neuropathy are usually symmetric and roughly speaking are not curable, while asymmetric is usually motor and can get cured. The incidence of peripheral nerve involvement may be influenced by the adequacy of diabetes control, which should in any event be optimal. The likelihood of developing neuropathy and the degree of severity increases with the duration of the diabetes and the elevation in blood sugar levels. Diabetic mononeuropathy multiplex is usually characterized by pain, weakness, and often has a vascular basis. The clinical deficit will depend on the nerves that are affected, while diabetic amyotrophy is due to radiculoplexopathy, polyradiculopathy, or polyradiculoneuropathy, characterized by pain, weakness, and atrophy of pelvic girdle and thigh muscles, which is typical, with absent quadriceps reflexes and little sensory loss. Diabetic mononeuropathy simplex is typically abrupt in onset and is often painful. CSF examination usually reveal protein, which is typically increased in diabetic polyneuropathy and mononeuropathy multiplex. Regarding treatment, no specific treatment exists for peripheral nerve complication of diabetes, except when the patient has an entrampment neuropathy and may benefit from decompressive procedures. Postural hypotension may respond to treatment with salt supplementation, sleeping in an upright position, wearing waist-high elastic hosiery, fludrocortisone 0.1 to 1 mg per day, and midodrine 10 mg 3 times daily. Treatment is otherwise symptomatic, and diabetic amyotrophy and mononeuropathy simplex usually improve or resolve spontaneously. Vasculitic neuropathy. The presence of painful mononeuropathy multiplex and systemic involvement such as weight loss, rash, or constitutional symptoms should prompt investigation for vasculitic neuropathy. The classical clinical presentation is acute mononeuritis multiplex, usually presenting with a painful mononeuropathy, which is often not at a site of compression. Again, not at a site of compression. There may be significant delay between the presentation of a painful mononeuropathy and the development of multifocal pattern. During this period, it is imperative to recognize atypical features of mononeuropathy that raise suspicion of vasculitis. Both small fibers as well as larger motor and sensory fibers are affected by ischemia caused by inflammation of the blood vessels. Types of vasculitic neuropathies. First, secondary to collagen vascular disease. Second, non-systemic vasculitis of the peripheral nervous system. Third, infectious vasculopathy, like infectious vasculitis caused by hepatitis C and B, HIV, cytomegalovirus, herpes zoster virus, and drug-induced vasculitis. Now I'll talk about acquired immune-mediated neuropathies. The common example is the Guillain-Barré syndrome, acute inflammatory demyelinating polyneuropathy, subacute inflammatory demyelinating polyneuropathy, and the chronic inflammatory demyelinating polyneuropathy. Now the famous example of acute idiopathic demyelinating polyneuropathy, which is known as AIDP, is the Guillain-Barré syndrome. Is an acute polyradiculoneuropathy that develops after 1 to 4 weeks after minor infective illnesses such as respiratory infections or diarrhea, particularly Campylobacter jejuni infection, inoculations or surgical procedure, or may occur without obvious precipitant. Acute inflammatory demyelinating polyneuropathy (AIDP) accounts for 80% of GBS, Guillain-Barré syndrome, cases. Miller-Fisher syndrome, it is a variant of Guillain-Barré, present roughly 5% of GBS cases and consist of a triad of ophthalmoparesis, areflexia, and gait ataxia, but patients often have partial presentations. Another less common variant where weakness is not predominant is Bickerstaff brainstem encephalitis, which is associated with ophthalmoparesis, hyperreflexia, gait ataxia, and encephalopathy. Other forms of AIDP of GBS are AMAN, acute motor axonal neuropathy, and AMSAN, acute motor sensory axonal neuropathy, are well characterized variants of GBS. What about clinical features of GBS? Symptoms and signs cease to progress by about 4 weeks into the illness. Patients generally present with distal paresthesia and limb pain, precede a rapidly ascending weakness that is bilateral and usually begins in the legs. It is often more marked proximally than distally, and is sometimes so severe that it is life-threatening, especially if the muscles of respiration or swallowing are involved. Facial weakness commonly develops. Muscle wasting develops if axonal degeneration has occurred. The deep, tender reflexes are typically absent. There may be marked autonomic dysfunction with tachycardia, cardiac irregularities, labile blood pressure, disturbed sweating, impaired pulmonary function, and sphincter disturbances. Investigations. The CSF often show a characteristic abnormality with increased protein concentration but a normal cell count, which is called albuminocytologic dissociation. Abnormalities these may not be found in the first week. However, electrophysiological studies may reveal marked slowing of motor and sensory conduction velocity. The time course of the electrophysiological changes does not necessarily parallel any clinical developments. Treatment. Plasmapheresis appears to reduce the time required for recovery and may decrease the likelihood of residual neurological deficit. It is best instituted early, and it is indicated especially in patients with severe or rapidly progressive deficit or respiratory compromise. IVIG, intravenous immunoglobulin, 400 mg per kg per day for 5 days, appears to be equally effective to plasmapheresis and should be used in preference to plasmapheresis in adults with cardiovascular instability and in children. The two therapies are not additive. Therapy is otherwise symptomatic, the aim being to prevent such complications such as pressure sores, venous thrombosis, respiratory failure, and vascular collapse. During the phase of the deterioration, regular monitoring of respiratory function is required, and for this reason, patients who are severely affected are best managed in the intensive care unit, where facilities are available for monitoring and assisted respiration if necessary. Prognosis. The disorder is self-limiting and improvement occurs over the weeks or months following onset. About 70 to 75% of patients recover completely, 25% are left with mild neurological deficit, and 5% die. The prognosis is poorer when there is evidence of a preceding Campylobacter jejuni infection, and a more protracted course and less complete recovery are also likely when axonal degeneration rather than demyelination is the primary pathology. advanced age and the need for ventilatory support are more rapid onset of symptoms may also predict a poorer prognosis. The chronic form of GBS, can we say it is chronic inflammatory demyelinating polyneuropathy, CIDP. It can also be classified or has variants like multifocal motor neuropathy with conductive block, MMN, or multifocal acquired demyelinating sensory and motor neuropathy, MADSAM, or distal acquired demyelinating symmetric neuropathy, DATS. The CIDP is clinically similar to GBS, except that it follows a course characterized by relapses or a chronic progressive course, and no improvement is apparent within the 6 months after onset. Its cause is not known. Examination of the CSF reveals findings resembling those in GBS. The electrophysiological findings indicate demyelinative neuropathy with superimposed axonal degeneration. The disorder is often responsive to treatment with corticosteroid, which may have to be continued on a long-term basis. Treatment with IVIG is also effective as initial or later therapy. When used as the initial therapy, it has advantage of fewer side effects than prednisolone. A plasma exchange is another effective immunomodulatory therapy. In non-responsive patient, a treatment with azathioprine or cyclophosphamide may be helpful. Finally, the entrapment syndromes of upper limbs. Certain peripheral nerves are particularly susceptible to mechanical injury at vulnerable sites. The term entrapment neuropathy is used when the nerve is compressed, stretched, or angulated by adjacent anatomic structures to such an extent that dysfunction occurs. Carpal tunnel syndrome is the example. Compression of the median nerve can occur in the carpal tunnel at the wrist. Carpal tunnel syndrome is common during pregnancy and can occur as a complication of trauma, degenerative arthritis, tenosynovitis, myxedema, and acromegaly. Early symptoms are pain and paresthesia confined to a median nerve distribution in the hand, that's to say involving primarily the thumb, index and middle fingers, and the lateral half of the ring finger. There may be pain in the forearm and in occasional patients even in the upper arm, shoulder and neck. Symptoms are often particularly troublesome at night and may awaken the patient from sleep. As the neuropathy advances, weakness and atrophy may eventually develop in the thinner muscles. Examination reveals impaired cutaneous sensation in the median nerve distribution in the hand, and with the motor involvement, weakness and wasting of abductor pollicis brevis and opponens pollicis muscles. There may be a positive tunnel sign, which means percussion of the nerve at the wrist causes paresthesia in its distribution, or a positive response to Fallon maneuver, that is done by flexion of the wrist for 1 minute, exacerbates or reproduces symptoms. The diagnosis can generally be confirmed by electrophysiological studies which show sensory or motor conduction velocity to be slowed at the wrist, and there may be signs of chronic partial denervation in the median supplied muscles of the hand. Regarding treatment, if the symptoms fail to respond to local corticosteroid injections or simple maneuvers such as wearing an nocturnal wrist splint, so surgical decompression of the carpal tunnel may be necessary. And thank you.